Good evening, ladies and gentlemen. I'm just giving about half a minute more just for people to join. There are still plenty of people joining. Okay, right. I think we've got a lot of new viewers. My name is Chris Foster. I am a pathologist at the Center for Human Metabolomics at Northwest University. And I have the pleasure of introducing Dr. Sharika Raga this evening, who will be speaking about spinal muscular atrophy, emerging therapies, and the associated ethical dilemmas. So Dr. Sharika Raga is a pediatric neurologist with a special interest in pediatric neuromuscular diseases. Presently, she is part-time PhD fellow registered with the University of Cape Town. Her research forms part of a multi-center study with the International Center for Genomics Medicine in Neuromuscular Diseases study, based at University College London. Dr. Raga is also a sub-investigator for a clinical trial involving patients with spinal muscular atrophy, currently taking place at the Red Cross War Memorial Children's Hospital. Apart from her research interests, clinical neurology remains one of her primary interests. She has been working as a pediatric neurologist at Constantia Berg Medical Clinic part-time since 2018. Dr. Raga also enjoys teaching both at undergraduate and postgraduate levels and undertook a part-time post teaching undergraduate students during 2021. So I think we can't have a more appropriate person to educate us about spinal muscular atrophy, and I look forward to your presentation, Dr. Raga. Thank you.
Thanks, Prof, for the kind introduction and for the opportunity to speak this evening. All right, these are my disclosures. Okay, so what are the realities and challenges that we are facing in our country? So the true prevalence of neuromuscular diseases is not known, particularly in low and even upper middle income countries, and as such, the true burden of disease is not defined. This challenges motivation for adequate services. It also reflects a combination of a limited clinical skills, as many patients throughout the continent are often mislabeled with cerebral palsy, and who in fact actually have a low motor neuron or neuromuscular disease. The lack of access to diagnostic tools, and that range from, not having access to basic creatine kinase, muscle biopsies, or molecular genetics, and the expertise associated with interpreting these results. In addition, other challenges include limited access to trained rehabilitation therapists and orthotic centers. So what are the aims of care? Well, apart from making a diagnosis, the key issues for families would be genetic counseling and the implications of having a genetic disease, and then more recently, targeted therapies that have now become the forefront of neuromuscular diseases worldwide. But overall, apart from these fancy therapies, it comes down to good management, and that would come down to standard of care, which would encompass optimizing motor capacity in these patients, avoiding complications, and planning optimal education placement for these children. Just to emphasize, this is standard of care and not state-of-the-art treatments. So spinal muscular atrophy. Well, just to give you a bit of a historical perspective, back in 1891, Verdner described the condition. And in 1995, the SMN gene was discovered. Not very long after the gene was discovered, in 2017, was the first gene therapy approval by the FDA for SMA. So you can see from the time the gene was discovered to when the therapy was made available, it wasn't a very long period. So what is SMA? Well, it is the commonest inherited cause of infant death. The incidence is 1 in 6,000 to 1 in 10,000. and it is the second most common autosomal recessive disease in childhood, secondary to cystic fibrosis. So what happens? What is the pathophysiology? Well, there's a progressive loss of motor neurons. You get degeneration of the alpha motor neuron in the spinal cord, in the anterior horn cell specifically, and then you get progressive muscle atrophy, weakness, and then paralysis. So what is the genetics? So all of us, we all have 2 copies of the SMN gene, SMN1 and SMN2. Now, if you do have SMA, there's basically a homozygous deletion of SMN1. Now, the SMN2 gene can take over up to 10% of its function, can actually be a functional protein, and 90% is an unfunctional protein. So in essence, if you do have SMA and the SMN1 is not working, the number of SMN2 copies one has will determine the clinical severity of the disease. This concept is incredibly important when it comes to therapies, which we will talk about in more detail later on. Now, there are different types of SMA, and that is dependent on the clinical phenotype. So, in a nutshell, children with SMA type 1 present in the first few months of life, and these are children who are never able to sit independently. Children with SMA type 2, they present usually less than 12 months of age, but usually a little later than the SMA type 1, and these are children who are able to sit, but they're unable to stand unsupported. And then SMA type 3s, those usually present much later, and these are children who are, or even adults in fact, who are able to walk and may later lose ambulation. So the classic phenotype. So many centers depend on clinical as well as basic investigations to confirm the diagnosis. And just to highlight some key clinical features that assist the clinician to make a diagnosis, or may, that will assist the clinician to suspect the diagnosis of SMA rather. So proximal muscle weakness, that will affect the shoulder and hip girdle, and usually affects the hip girdle a bit more severely than the shoulder girdle. The child may have a bell-shaped chest, which is very classically seen on the chest X-ray picture on the right-hand side of your screen. Tongue fibrillations or fasciculations, a distal tremor. They have a normal facial expression and normal intelligence. And just to highlight the picture of the ECG, you may wonder, well, why did I put a picture of the ECG? Well, we very often get phone calls from clinicians out in the peripheral hospitals who don't necessarily have access to very much. And you get a call saying that they suspect this child, they've got a hypotonic child who's very weak, and suspect a diagnosis of SMA, but they don't have access to anything else. And often they do have access to the ECG machine. We ask them to do ECG, and if you look at the baseline of the ECG, very often the baseline may not be a straight line due to the fibrillations from the heart muscle itself. So it can be quite a helpful tool. Not to forget, in our setting, the differential diagnosis. So apart from SMA, just to think about other causes of a floppy child, which would in our setting very not uncommonly affect the causes such as enterovirus, metabolic causes such as Pompe disease, neuromuscular junction disorders such as the congenital myasthenic syndromes or myasthenia gravis, for example. But more recently, what we are discovering is that the SMA and the SMN protein is actually ubiquitously expressed in many more organ systems than just the neuromuscular system. And we are discovering more about this protein that may contribute to gastrointestinal, metabolic, as well as endocrine defects. This also has implications for treatments, which we will touch on again later in the presentation. So what is the epidemiology? Well, Worldwide, it is the second most common autosomal recessive disorder, as we have mentioned, in European white ancestries after cystic fibrosis. The carrier frequency is 1 in 40 to 60, and the incidence is about 1 in 6,000 to 1 in about 11,000. The birth incidence in Black South African patients is estimated to be slightly higher, at 1 in about 3,500, and that was based on a paper published in 2007. The carrier incidence is estimated to be 1 in 23 white South African patients and 1 in 50 Black South African patients. However, it is important to note that these results were not reproduced in the Foster paper in 2020. Again, just to highlight that these findings were also not reproducible in the Western Cape region, where SMA patients were screened over the last 20 years, and all patients with genetic confirmation of SMA complied with the international guidelines, and all patients with exclusion features had other conditions. So just to conclude that all the patients in the Western Cape region conformed to the international cohort. Again, just to highlight that SMA is a result of a homozygous deletion in exon 7 in 94% of cases worldwide. There was a very interesting paper that was published locally by Forster et al., which basically concluded that about 51% of the indigenous African Black population, about close to 70% of those patients did not have a homozygous deletion of SMN1. They only had a heterozygous deletion, and the assumption or the hypothesis was that the second allele was the hit was either due to a point mutation or complex rearrangements. That was the hypothesis, and that was looked at again later on, a couple of years later, and not reproducible. These findings have a huge implications for counseling, implications for newborn screening rollout, and access to pharmacogenetic interventions. And basically, further studies are required looking at our local population in order to get to the bottom of this, so that we can counsel our patients appropriately, especially with therapies that are being made more available. What is the management of spinal muscular atrophy? Well, the approach depends on the type, and this is based on the clinical type of SMA, as we had discussed earlier. And there are standard of care guidelines, which I will show you a picture of in the next slide. But basically, the children with type 2 SMA are the ones who require the most care. So they're the ones who require lots of physio, appropriate schooling, and they're very bright children, often going to university, if they manage to survive the schooling years. The type 1 patients often, or traditionally rather, were offered supportive care and were not traditionally offered ventilation. And the type 3, those patients tended to live into adulthood, and so the ongoing counseling is really important. So these are the management recommendations for SMA that was published in 2018. And just to note that this was prior to taking therapies such as gene therapy into consideration. There are new standard of care guidelines that are currently being discussed, taking into consideration the new phenotypes that are emerging due to the new treatments that are available. Standard of care includes a multidisciplinary approach where 5 core areas are addressed, namely diagnostic or new interventions, respiratory, pulmonary, gastrointestinal, orthopedics, and palliative care. Also, just to note that there are barriers that facilitate care, and that's at various levels from a caregiver's perspective, and that would be from local care to support care providers, and then also other challenges accessing specialist care in specialist centres. And then palliative care and advocacy groups are incredibly important for these families. Early counselling, carer support, early interventions, planning for non-invasive ventilation, and avoiding crisis management. And again, just to emphasize the multidisciplinary team approach. Okay, so now that we've covered the basics, we're now going to move on to the interesting part of the talk, which is the therapeutic strategies. So we will be speaking about some of the therapeutic strategies, targeting various different aspects of the disease. And I'm going to first focus on the target of the SMN1 and SMN2 genes. So SMN1 gene replacement. So we've said in SMA, you don't have a working SMN1 gene. And so the purpose of a SMN1 gene replacement therapy or gene therapy works as such. So you have an AAV9 vector, it enters the motor neuron cell. The AAV9 vector delivers the SMN gene to the cell nucleus. And the SMN gene is introduced to target cells as recombinant or self-complementary DNA. This results in rapid reactivation of the SMN1 gene and or SMN1 rather, and then continuous production of the gene. So treatment or gene therapy as of 2021 was approved by the FDA in high middle income countries. And then just to mention, so the gene therapy that we've just spoken about is the onasemnogene abeparvovec or Zolgensma, which is the trade name. But then also just to mention that nusinersen and risdiplam, they target the SMN2 and they target the upregulating of the SMN2 to a full-length SMN2 protein. Nusinersen is given intrathecally, and risdiplam is an oral medication. This is the cost, which is, the main issue that we are having accessing these treatments. So the onasemnogene abeparvovec or intravenous gene therapy is actually the current cost is $2.5 million at the moment. Risdiplam, as you can see, it's just over $200,000 per annum, and nusinersen $375,000 per year. So, do these drugs work? Well, in infantile SMA, nusinersen has reduced half the risk of permanent mechanical ventilation, has reduced mortality by 63%, and 41% of the treated arm had motor function improvement compared to controls, and that was published in The Lancet back in 2017. The greatest benefit was found in pre-symptomatic children within 3 months of disease onset. The older children who had onset after 6 months and were treated when they were symptomatic still showed improvements compared to controls, and this was predominantly found in the motor function. So risdiplam is an oral medication. It's a small molecule aimed at modulating SMN2 splicing in a similar manner to the intrathecal injection of nusinersen, but the advantage is that it's via an oral route, so it doesn't require hospital admission, ICU care, and anesthetic, especially for children. So the risdiplam has got good safety outcomes. Clinical trials have been completed, and we'll go through some of these in this slide, where it goes through all the fish studies. So from the rainbow fish, firefish, sunfish, and jewelfish, and basically these the initial study were on pre-symptomatic children. The firefish study was on children between 1 and 7 months of age. The sunfish in older children, early adults from 2 to 25 years of age, and in the jewelfish study, and those were extending into adulthood up to 60 years of age. And basically, these are the results. So in the younger age group, or part 1, 41% of infants who received the risdiplam were able to sit without support for at least 5 seconds. 6% of infants were able to stand with support. 53% of infants were able to maintain upright head control, and 59% of infants had a CHOP INTEND score of greater than 40. The long-term findings after 12 months of being on treatment, 93% of infants were alive at 12 months of age. 95% of infants had maintained their ability to swallow after 12 months of treatment. 49% of infants did not require hospitalization during the 12 months that they were on treatment, and that there were no drug-related safety findings that led to the withdrawal of patients from being a part of the study, which is quite impressive, actually. So, on to gene therapies. Zolgensma or anasemagene beparvovac. So this, as we had mentioned earlier, is the AAV9-based gene therapy. It was approved by the FDA in May 2019, and it consists of a single intravenous injection. However, the key thing is that the patient needs to have AAV9 viral titers less than 1 in 50 prior to the infusion. And at the moment, there are studies that are taking place looking at intrathecal gene therapy at lower doses in older children. And the reason why in the older children they're looking at intrathecal therapy is because the dose is actually weight-based. And so the concern was that the older children would require a very large dose, and the concern was that the drug wouldn't go to where it was actually needed. So the intrathecal administration is targeting, trying to get the drug where it's needed in the motor neurons. So the SPRINT and the STRIVE studies were looking at intravenous gene therapy in children who were symptomatic with SMA type 1 with either 2 or 3 copies of SMN2. The Ophelia study was looking at the long-term outcomes, and that's phase 4 trials, which are currently still taking place. And then the STRONG study, the STEER study, and the STRENGTH study is also looking at gene therapy, so Zolgensma and anasemagene beparvovac, but looking at the intrathecal administration route. And those would be for children who are a bit older, so over 2 years of age, but less than 18 years of age, who receive intrathecal gene therapy. So just a summary of the findings. So the SPRINT study design. So it looked at intravenous gene therapy in pre-symptomatic infants who were less than 6 weeks of age at the dosing. And it divided the patients up into those who had 2 copies of SMN2 or 3 copies of SMN2. And these were the findings. So in those children who had 2 copies of SMN2, just to remind you, these are pre-symptomatic children, 100% achieved sitting without support, 71% achieved standing alone for greater than 10 seconds, 71% achieved walking independently, which is remarkable. 64% of patients with 2 copies of SMN2 had gross motor performance similar to children of the same age who did not have SMA. Also, the mean CHOP INTEND score, which is one of the outcome measures we use, was also similar to normal developing children. In those children who had 3 SMN2 copy numbers, 100% achieved standing alone for more than 3 seconds, 93% achieved walking alone, and 93% achieved standing with assistance. In those children with 3 copies, again, their motor function, 100% of patients had gross and fine motor performance similar to same-age children at 24 months of age who were not affected by disease. So the study design for the STRIVE study, there were 22 patients less than 6 months of age with 1 to 2 copies of SMA2. It was open label, single intravenous injection, and they were compared to children who were also less than 6 months of age, who had SMA type 1 and 2 copies of SMN2, basically, and who were not treated. And the primary outcome was looking at independent sitting for 30 seconds or longer at 18 months of age study visit. And 22% of patients achieved functional independent sitting for at least 30 seconds or longer at the 18-month follow-up. So just to highlight, it's all very well to speak about these therapies, but what are the adverse effects? So some of the most common side effects include hepatotoxicity, and that would be a raised transaminases specifically, and also a thrombocytopenia. But none of the patients, so patients often had elevated enzymes, remained asymptomatic, and also patients whose platelet levels had dropped also did not demonstrate any associated bleeding events. So just to note that, even though there were some aberrations in the blood results, it did not translate to being clinically significant. This just highlights that that patients in these studies, they had ALTs or raised transaminases, but it did not translate to to being clinically significant. And this was just a workshop that was held, and you can look up this paper. It was one of the ENMC international workshops on management of safety issues following gene therapy. Now, the STRONG study was an open label ascending dose study to look at the safety of intrathecal gene therapy in the treatment of spinal muscular atrophy. And it looked at low dose and high dose, which was double the dose. And it looked at children who were younger, so between 6 and 24 months, and then in the older age group. And then looking at the long-term safety of these drugs. And the key findings, or the primary endpoint, so again, serious adverse effects in these children primarily were hepatotoxicity, thrombocytopenia, and cardiac events. But again, none of these translated to, being clinically significant, and none of these children required invasive ventilatory support. So the conclusion was that the safety profile of intrathecal gene therapy was consistent with the cumulative experience with intravenous gene therapy for patients with SMA. And the key findings, so again, patients who were between 6 and 24 months of age, one of the 13 younger patients who received the intrathecal gene therapy achieved independent standing. Also, there were improvements in the Hammersmith scores in the older patients. The secondary endpoints, one of the children walked independently. Unfortunately, there were no older patients who achieved independent walking, which is not really surprising. And this just emphasizes that the earlier the treatment is given, the greater benefit is achieved. So this is our study coordinators. We Red Cross Children's Hospital, as Prof. Foster had mentioned, is one of the sites for the STEER study. It's a multi-center country study. It's competitive worldwide recruitment in age brackets between 2 and 18 years of age. It's got very rigid inclusion and exclusion criteria, and patients are randomized into 2:1. However, at the end of the study period, so at the end of 12 years, children who didn't receive the treatment then will receive the treatment. So everybody gets it in the end. And we had opened the study up to countrywide. We were the only site, but we've had patients from all over South Africa be a part of this. The recruitment is now closed, and we're actually heading toward the end stage of this study. Just to mention, one of the major reasons for patients being excluded on this clinical trial was the very high AAV titers in our population. And it's very interesting because a lot of the patients who had high titer levels actually were actually very well. And so, it's interesting, there may be cross-reactivity with other viruses, but unfortunately, many of our patients were excluded based on that criteria. Just to mention, in the past, there was a compassionate access drug program giving patients were placed into a lottery system, which is incredibly unethical, but it was to receive intravenous gene therapy, but this was stopped at the end of 2022. I'm going, so, the next thing, looking at the availability of gene therapy. So as we have mentioned, the cost is exorbitant, but there are many high-income countries that are offering gene therapy. And many high-income countries are actually looking at crossover or dual treatments for SMA at the moment. Many countries are doing newborn screening and interventions. Long-term outcome measures and sustainability of the interventions are also being investigated. And then the ethics of access and patient selection is a key factor, especially for us. Now, we're far away from combination disease modifying treatment, but there are lots of different combinations of treatments happening based on all kinds of factors, and it mainly boils down to accessibility and cost in many areas of the world. And again, just to mention, newborn screening is taking place. Again, many countries are doing it, but many countries aren't doing it. But if you are going to invest so much money in a therapy or a treatment, you're going to get more value of the treatment or the intervention the earlier you give it. And so newborn screening, treating children pre-symptomatically, would be the gold standard. Okay, I'm not going to go through the details, but I have alluded to the fact that, if you are going to spend so much money on treatment, then, implementing newborn screening is going to make a lot more sense. And then the ethics of access to treatment. So again, my point of view is, if you don't have access to treatment, there's no point implementing newborn screening. But just for those of you who aren't aware, recently risdiplam, which is the oral agent that upregulates SMN2 expression, has been approved and available in South Africa. The problem or issue is the cost, even for those patients who have a medical aid. And so the ethics of availability. So it comes down to the basic ethical principles of autonomy, beneficence, non-maleficence, and justice. And having a child born with SMA in this country or any other country on the African continent where therapies are not locally available, but then you Google and you read and it is available in other countries, begs a lot of questions for you as a parent. And, there are many instances where parents have started crowdfunding, and there are instances where patients would then move or try to move to a different country to get treatment for their children. And, all these issues are relevant. But again, it really comes down, it comes down to, what are we going to do and how are we going to get access to these drugs? So, there's a lot of ethical questions that are coming out of this. And, just to highlight that gene therapy isn't a cure. So yes, it does benefit children and it does help, but it's not going to take the disease away. I think if the child is treated once they're symptomatic, they are still going to have morbidities or complications. And, you know, the question is, can you justify the cost of giving a child who's symptomatic, you know, the treatments? And these are just some of the questions that, you know, I don't have the answers to, but it's just something to think about. Again, there's an explosive level of outreach related to interventions for SMA, not just in the medical literature and congresses, but in social media. And again, there's a high level of expectation and emotive stories that are making the rounds. And, you know, it's amazing how much of an impact social media has played, and some families who feel that, you know, if their child has received, for example, nusinersen or risdiplam, they know that they want the gene therapy because that's the better treatment to get, and then they go to great lengths to try and get it for their child. So, you know, again, the cost of, for example, nusinersen, which is one of the first drugs that became available, it's intrathecal injections, and it's not just the cost of the drug itself, but it's also admissions to hospital, administration, intensive care unit costs, etc., etc. And then also the toll it takes on the family every time a child needs to go in and go through this. And so, you know, it's again, you know, geographic access to care, you know, the ethics of expanding treatment centers and specialists who are available in those centers who are able to administer such treatments. And again, a team of people is required. You know, a clinician can't do this on their own. And then, you know, this also begs the question, do we always need to treat patients with spinal muscular atrophy? You know, children who have SMA type 1 who are symptomatic, you know, what are you actually doing by giving therapy? You know, are you just delaying the inevitable, or are you actually providing some sort of benefit for the family? So there are different perspectives from different regions of the world, and I'm not going to go into detail, but you can have a look at these review articles. And, you know, that there needs to be some sort of ethical conduct in the care of children with SMA, and interventions need to be standardized in general. And, you know, whether, you know, to sometimes put these decisions on individual clinicians at the time, you know, it's also perhaps unfair, and maybe a committee is required where, you know, a group of people will then decide whether, you know, the treatment should be given or not, if it is available. And then also, you know, should we rather focus on first newborn screening, carrier screening, prenatal screening, pre-implantation genetic diagnosis, gene editing, to try and, you know, catch the disease before it becomes symptomatic. And this is just a lovely article looking at the caregiver's experience of children who have SMA type 1, and, you know, the range of emotions that they have to go through. And, you know, as I had mentioned, nusinersen is not an oral drug. It requires repeated hospital admissions, intrathecal administration, which is traumatic for the child as well as their families. Okay, we have mentioned that, you know, it's the rollout of gene therapy has now opened the gates, and it's raised a whole lot of questions, not just in the scientific field, but also financially, socially, and ethically. And if you think about worldwide, who has access to gene therapies, for example, and the rest of the world who are just lagging behind, what are we going to do as a global community to give all patients equitable access? You know, and we have to probably try and think a bit more innovatively to come to sort of some kind of an agreement. But we need close cooperation between pharmaceutical industries, society, to develop orphan gene therapies. And we probably need to, you know, involve policymakers and governments and, you know, non-governmental organizations as well. And, you know, I think parties should, you know, be open to negotiating a fair locally affordable drug price for those countries that are not going to be able to afford $2 million, $2.5 million for one dose of medication. So, and we do need prolonged observation of new cases coordinated by society to provide real-world data for modern complex registry evaluations of gene therapy and the long-term effects. So basically, yeah, we need to look at how we're going to make these drugs more accessible and affordable to the majority. I'm going to skip over because time is going. So just to conclude, the overall care of children with SMA remains clinical and symptomatic. Early intervention is critical, and you do require a multidisciplinary approach to care. So basically, whether you have access to gene therapy or not, standard of care is still the most important, because whether you have gene therapy or don't have gene therapy, standard of care always needs to be followed. The South African, cohort, has a unique set of genetic challenges and variances, and that needs to be explored further. And then gene therapy. So again, cost and access is an issue. The timing of intervention, is crucial. And then, if we are going to make these drugs available and accessible, having a newborn screening program implemented concurrently might be the better way to go in order to get the most benefit from spending so much on these drugs. And then again, issues of long-term safety and maintenance of gains is also something we also need to just bear in mind. And that's all I have to say. So we can now, I guess, open the floor to questions.
Thank you, Sharika. That was very, very informative. I have a ton of questions, but I'm pretty sure I'm not going to get a chance to ask them. I see there's already 2 questions in question and answer. So yeah, if you want to ask a question, just post it in the question and answer section. Or alternatively, if you wish to be unmuted, you can also just inform us in the chat, and we will then unmute you and give you an opportunity to ask your question live. Okay, so I start off with a question from Azra Hura. I hope I pronounced the surname correct. Brilliant talk, Sharika. What contributes to the exorbitant costs of the drug? Manufacturing, research, profit, etc.
It's manufacturing and research and profit. It's probably everything.
And don't forget about the profit. I recently read an article to say that rare disease drugs are some of the most lucrative endeavors for pharma companies at a current day and age. So Philip Snyman is asking, don't you think that before we can start thinking about gene therapy, our country has to improve genetic services countrywide?
Completely agree. Completely agree. And I mean, it's very interesting. I don't want to delve too much into the STEER study, which we are a part of, because it's currently still ongoing. But just in general, having worked closely with patients from all over the country, I think we can do a lot better with improving the standard of care in these patients. And that's a good place to start, along with the genetic services. So yes, I couldn't agree more.
Chris Hendricks is asked to be unmuted. So Chris, you're welcome to ask your question.
Yes, I just wanted to give some perspective there, because I think you've heard the question there. And really, one of the challenges with the gene therapies, wonderful talk you gave in SMA. I don't want to take away what we're doing in the UK, but the production cost is actually exorbitant. And you will see there are multiple clinical studies which we're currently pulling, because the manufacturing cost is huge. To give you a perspective, to manufacture a single dose of gene therapy is somewhere between $500,000 and $750,000. which is to manufacture it. And that's been the biggest issue. So hopefully, come in the future, we'll find better methods of making it cheaper.
Thank you, Chris. Then we have a question from anonymous attendee. Are there any clinical trials in South Africa for SMA type 1? Maybe I went over your introduction too quickly, but please answer.
Not for type 1. We are currently doing a clinical trial for type 2 SMA patients between the ages of 2 and 18 receiving intrathecal gene therapy at Red Cross Children's Hospital.
Yeah, mistake on my side. It's type 2 study.
Mm.
Another question from anonymous attendee. Any current talks or buy-in from government to facilitate gene therapy?
No, there's, there are talks from, some pharma companies, but no, the cost is the issue.
Mm. Okay, then a question from Nula Kamananga. Excellent talk, Sharika. Very proud of you. You mentioned that some of the drugs reduce mortality. Is that mortality at 18 months or 5 years?
So it's actually both. And we find that these children are not requiring hospitalization. Because if you think about children with SMA, the reason why they die, to put it bluntly, is because of respiratory tract infections very often. And children who receive these therapies, they don't get respiratory tract infections as frequently as children not on therapy. So we know in the short and long term, it does reduce mortality. Yes.
Okay, then we have a question from Sydney Groevier. As a registered and certified advanced midwives, how can we make a difference in antenatal screening other than ultrasound by specialized sonography?
So I don't know whether you would actually pick up anything on sonography because these children will present. So even children with SMA type 1, they won't present at birth. They would become symptomatic, usually 4 to 6 weeks of age and sometimes a bit later. So I don't think you're necessarily going to pick up anything on ultrasonography. I think doing prenatal genetic testing, if it's available to the families, would probably be, helpful. But yes, for sonography, no. But what I can say is, just in general, and this has got to do with neuromuscular diseases and again, we've actually just in the process, so we just had an article accepted by neuromuscular disorders. We did a survey looking at the availability of care for patients diagnosed with neuromuscular diseases early, and just picking up basic signs like delayed gross motor development, a hypotonic child, referring them early. Those are basic things which are still missed in many areas. I mean, even we get referred patients quite late. So it's creating awareness about, if a mom is worried that, the child has delayed gross motor development, don't send them home and say, oh, there's nothing wrong, come back in 3 months' time. If you're not sure, ask someone or refer the child on. So I think those are little things that we can perhaps improve on in our setting.
Yeah, and I think another thing that we often experience is symptomatic treatment without seeking a diagnosis. So send the child to physiotherapy and occupational therapy, but a diagnosis was never made. So that's another thing that I can just comment on. Then there's a question from Sivuyishwe Mpundu. I hope I pronounced that correctly. Thank you for the amazing talk. Have you managed to motivate for gene therapy for any patients in the private sector? That's an interesting one.
It's a good question. No, the short answer is no. We have so the Arista plan, which has recently become available, it's the medical aid, not all medical aids are covering the cost, and they're actually making our lives quite difficult because Some medical aids are covering a part of the cost, other medical aids are not. And so the families still have to make co-payments, which is still for an average middle-class family on a medical aid is still a lot. So, you know, there seems to be a lot of inconsistencies amongst the different medical aids with risdiplam, which is a lot cheaper than gene therapy, but gene therapy, no.
And then a question from another anonymous attendee: is there any restrictions for South Africans receiving any treatments for SMA?
So the restrictions would be accessibility. So again, it's mainly accessing the drugs because of the cost. If you can pay for it and get it, we can give it. It's no problem.
Chris Hendricks is asking, is there a place for CK screening around 3 months of age?
Well, that would depend. Are you meaning CK screening in symptomatic infants or CK screening in asymptomatic infants? That would be my first question back to you.
In the whole population? Chris? In the whole population, because there are multiple neuromuscular early onset conditions, which when you've got nothing else, is this better than nothing else?
That's a tough one, because again, you know, you do a CK level too early, it's not going to be elevated, especially when you do it at a very young age and then you're going to miss things. I would rather say, go clinically, do a good clinical examination. If there's something making you worry that this child has a bit of head lag or is not doing what they're supposed to do in terms of their motor development, then I would perhaps screen those patients and follow. But to just routinely just do a CK, I don't think that's the way to go. And then who's going to vet the results? Because then you're going to sit with levels. And then the other, just to throw a spanner in the works, I mean, there are conditions with RNA mutations, for example, that has hyper-CKemias and, you know, all kinds of other things. So yes, it might help, but then somebody has to take responsibility for the clinical care of these children. So I first think starting with a good clinical examination is the way to go, because then you're following a pathway to care and not just treating labs.
Okay, Dwayne Moodley is asking, is there a system for us to receive any type of treatments? I think you have answered that. Is there anything else that,
I was going to say risdiplam is available. You can prescribe it.
You just can't get it, but you can prescribe it.
No, you can prescribe it. You can get it if a family has money and is willing to pay.
Okay. Then, yeah, Sydney Riviere is just thanking you for a great presentation. Brenda Flopper has posted the Newborn Screening Act sheet for SMA screening in the United States. Brenda, if there's a particular question, you're welcome just to send that to me. Maybe I can just get an opportunity to quickly ask you two things. The one is, in a metabolic lab, we're often confronted with Pompe patients where SMA is in the differential diagnosis. Now, you've given a good clue to making the diagnosis through ECG. We also use that, of course, for Pompe disease. Any other clinical distinguishing factors that you can point out to differentiate Pompe's from SMA?
It's a good question. A distal tremor. These children will have a very fine tremor. So you ask them to just, you know, even the kids, even if they're unable to lift their shoulders, even if they're just holding a toy, you'll see a fine tremor. The hands will just go. That often gives us a clue to SMA. I think that's the one thing that jumps out at me. And then the ECG can be quite helpful. And that's available in most cases.
Yeah, that is a very good tool that you've given us.
Fasciculations are very difficult in children, very difficult sometimes, but especially the young, especially the babies, because, yeah.
And my other question is, I'm glad that I'm in inherited metabolic diseases, because we have difficult variants to deal with. You know, we can often test for them enzymatically or metabolically as well and confirm the diagnosis. But how are we going to manage this? And it seems like there's a large number of patients, South Africans, that do not have deletions in exon 7 and SNM1. So how are we going to sort this out? Is there some kind of an in vitro assay or other assay that we could use to confirm the diagnosis, or do we need to follow them up, or how are we going to generate that data to ensure that we can diagnose these patients early on?
It's a good question. It's interesting because those findings were not found everywhere in this country, and they were also, whether they had other conditions, we're not so certain about, because we're not sure of the clinical phenotype, and that's what it comes down to, having a good clinical suspicion. I think just, again, looking at all the patients diagnosed with SMA more recently and then going back and confirming whether they actually had SMA or not, I don't know. And then kind of working together with everyone in the country to see whether, because we didn't find it in the Western Cape. All our Black patients are, consistent with their genetics are consistent with the international cohort. So we're not convinced that, there's a different genetic, I don't know, explanation. But yeah, I'm not certain. I don't actually know the answer.
Okay, Philip Snowman is asking, do you often find sweaty palms, autonomic dysfunction in these patients?
I find it in children with congenital muscular dystrophy. In that spectrum of disease, I often find sweaty palms, or in the hereditary neuropathies, but not specifically for SMA, no. But they can have, hold on, in the older patients, very interesting. The older patients can have some features of, peripheral nerve involvement. And it's actually one of the aspects that is being looked at more closely in the children who are now in the trial for the intrathecal gene therapy.
Okay, it looks like we have covered all the questions. Sharika, again, thank you very much for a very informative talk. I think you've opened up a lot of issues. Certainly, we need to have more discussions on how we're going to manage our patients in the era of gene therapy and other exciting therapies, and how we're going to be able to make it available in South Africa. I think you've briefly mentioned an advisory board, which is something that we've also mentioned in the past. So I think there's lots of interesting discussions that should follow. So thank you very much for enlightening us, and I hope that everybody who attended enjoyed it as much as I do. Thank you for your time, and we look forward to seeing you next time.
Thank you for the opportunity.
Goodbye.
Bye.